Hello, welcome again. Dr. Anthony Gonzalez here with Miami Community Health. We're here again to bring you another important health topic. Many of you have heard about hospice and hospice care. Maybe you've had a loved one who's been involved in hospice care at the end of life. But there's another term that I want to introduce today, and that's called palliative care. So what's the difference between hospice and palliative? What is palliative care? So today, to explain it to us, I brought with us a palliative care physician, Dr. Sonia Tarras, to welcome us and talk with us about what is palliative care. Welcome, Sonia.
Hi, thank you for having me, Anthony.
All righty. So we're going to talk a little bit about your specialty, but tell everybody a little bit about you and what you do.
Okay, sure. So basically, I'm a palliative care board certified physician. I trained in internal medicine, and I'm originally from Nicaragua. And I've been with Baptist Health South Florida for about close to a year now, and I'm very happy to work with a very close-knit team who shares the same passion as I do for palliative medicine. And, we're striving to do every single day the best that we can in order to improve our patient's life.
Yeah, and actually it seems much longer because we've worked on so many patients together and so forth. So a year. So I was surprised to hear that. All right, so let's start.
That's good to know, though.
Yeah.
You see, that we'll get into that, but that's good to know.
All right, so what is palliative care?
Okay, so palliative care, basically, it's a specialized medical care for patients with serious illness. Its focus is to maintain or improve the quality of life of these patients, whether that be addressing symptom management or stressors that come along with the context of having a serious illness. And we work as an interdisciplinary team. We have our own social worker, our pastoral care, our nurses, and our doctors who work together in order to coordinate plan of care to add an additional layer of support to our patients that essentially need additional care and palliation of their symptoms.
And is palliative care only in the hospital inpatient setting, or is it also in the outpatient setting? If somebody has a chronic condition and they need palliative care, can they get that outside of the hospital?
Absolutely, absolutely. Palliative care there's different kinds of formalities. We have our inpatient palliative care, which is what we do at Baptist Health, and we have our outpatient palliative care. Specifically, we refer and see patients intertwined with the palliative oncology clinic at the Miami Cancer Institute. For example, they may be following a patient early on, hopefully early on in their disease course, and if for whatever reason the patient has a pain crisis, they're admitted to the hospital. We see them for cancer-related pain. We may adjust medications, send them on a different regimen, and we communicate with them what is the adjustments that we made, and they continue in the community. But in itself, we can see a lot of patients in the community as long as they have a serious illness and they require symptom management, discussions about goals of care.
All right, so obviously this is a very specialized area within medicine, and you're an internal medicine doctor. What drew you to that area of palliative care?
So that's a great question because I'm a young physician in a sense, right? And I didn't come to terms about palliative care early on. I realized that was something that I liked because I explained earlier that I'm from Nicaragua. I actually did my I was a medical student there. I trained there. And, when you work or you train in a third world country that is completely underserved, back when I was in 2021, I think one of my vivid memories was going through the oncology ward, and some people do not have the resources to get disease-modifying therapy, whether that be chemotherapy, radiation, immunotherapy trials. So sometimes they have to go to Costa Rica, they need to get sponsorships, and that's just not everyone's reality. So I realized at a young age that what we did for these patients was treat them in a palliative way. We treated their symptoms, we had discussions with their family, what's going to happen, how the disease may progress, and how do we make every day count? How do we make every day important for them? So that's what I learned when I was in medical school.
So you were providing palliative care
Yes.
and practicing palliative care even before you were a doctor.
Right, exactly.
Wow.
And a lot of us do it when we are faced with situations where people cannot receive medical treatment, right? And then I went on to in New York. I did my my internal medicine residency. We didn't have a palliative care service until I was in third year resident, But because you would know the hustle and bustle of being a resident, you got to draw blood, make the progress note, make sure the patient is ready to be discharged. So when I saw them and I was a third-year resident, most of my time was spent in the ICU. And I saw them go into the rooms and they would have these family meetings and these long conversations, and they would stay there for a substantial amount of time. And I said, wow, these people are really advocating. They're really taking their time to explain things and how the process may be, and just providing this listening. And so that was another way that I felt, oh, I think I like this field. And then ultimately, when I did graduate, I worked as a hospitalist in the state of Maine, and it was a community hospital. We didn't have all the specialists there, but it was elderly population. So we had 80s and 90s-year-old, and I would, as a hospitalist, ask them about, their provisions of treatment. What do you want if something like this were to happen? And very minor times did I realize that they knew what I was talking about, or anybody had brought that stuff up to them. So then I realized I've been doing this in different levels of my career,
right.
And this is what I wanted to do. And, I cannot express the gratitude that I have being able to have that relationship with my patients, and I wouldn't change it for anything.
Wow, that's awesome.
Even though people always think, aren't you always sad? Aren't you depressed? No, not at all.
No, because you're going to explain to us also now the difference, because, the big difference, palliative care, hospice care.
Right.
And so before you get into what palliative care, let's clarify for everybody what hospice care really is. And then, of course, let's differentiate that from what you're doing and obviously improving patients' lives.
Okay, so this is such a great question because everyone confuses it all the time. So hospice is basically a philosophy of care in which patients have a terminal condition and they are not receiving any longer any anti-tumor therapy, whether that be radiation, trial, immunotherapy, chemotherapy, and they have a life expectancy of 6 months or less, right?
Okay.
Whether this may be that by choice they're not receiving treatment, or because they have no longer become a candidate for treatment because they have adverse reactions, side effects, or because simply they no longer tolerate treatment, or the disease has become refractory to treatment, right? So it's basically the 6 months or less of life expectancy no longer receiving anti-tumor or disease-modifying therapy. That's the main difference. Palliative care can be given at any stage in the disease process, and we would prefer after diagnosis because we feel that the report is better, quality of life is better, and just having that relationship with patient and families is essential for someone to do good during this journey.
So there's no limit of time. One moment you have a diagnosis, it has to be a chronic diagnosis, of course, and then the moment you have that diagnosis, then you can begin palliative care.
100%. And some of the similarities that people may confuse is that hospice does come with an interdisciplinary team as well. They have their own hospice physicians, their nurses, their nutritionists, pharmacists, and they also have very special services like bereavement, and that's pretty much counseling for the grieving family members, right? And this is a special thing because they follow patients' families for up to a year after their loved one have passed away. And it's very important because it's specialized training in which, think about it, what if there was young children in the family, or there was adolescents that don't know how to express their grief? So these bereavement counselors, they have endless resources in talking about forums, groups. I've seen camps. They help in so many ways, right? And obviously, hospice sometimes gets a bad rap because people don't take advantage. I was a hospice physician in New York for many years before I came here, and I saw patients be on hospice for days as opposed to months, and we could have done
So much more.
a little bit more,
Yeah.
right? And that's kind of what we're trying to get everybody on board with. Death, of course, is scary, but when we have a serious illness and things have changed, talk about that change in a way that we're not scaring people, and we can make their lives easier, and every single day count.
Yeah, no doubt. I saw hospice care with my mom, and how at first we were a little concerned about it, but we saw the benefits of it and so forth.
Right.
We obviously asked where my mom didn't want it because she was still sound mind and she's like not thinking of death. So what are you guys treating when you're involved with the patient in palliative care? Let's talk about some of the symptoms and how do you help a patient and the family, I guess.
Okay, so that's a great question. Basically, what we do with patients is we do a full comprehensive assessment, right? Everything from symptom management that can be pain. In most cases, that's our number one symptom, cancer-related pain. We have shortness of breath or dyspnea. We have fatigue, anorexia, constipation, its counterpart diarrhea, unrelenting nausea and vomiting. So we do an assessment from all the symptoms that they may benefit from treatment, right? And we do that in a very meticulous way, and we follow patients closely. Besides that, we also do advanced care planning and goals of care, because as a disease is diagnosed to either its progression or its, some people may go into remission, their goals of care every step of the way are important to discuss with the patient and their family member, because the reality is that when you have a serious illness, you just don't, it's not just the patient that is.
It's the whole family.
It's the whole family. It's the nephews and the uncles and the children, the grandchildren. It's the whole thing. And I think what's important about the goals of care is that people understand that it's the patient's goals of care that we're trying to honor and advocate for, right? Not so much what I may make a recommendation, you as a doctor may have an opinion, but we have to see the patient as an entire person, right? We don't see them as patient in 1532. No, this is a person with goals and wants and just a lifestyle with a religion, a culture, and this is the things that we are extremely mindful of, and we are trained listeners in a sense, and sometimes we can spend hours in a room and then go back, and if we identify that this patient needs not only the doctor, but this patient may need our social work to go give them extra support, or they need our chaplain to give them extra support, we can call on those extra resources to help. And it may sound cheesy, but I guarantee you that it really, really helps everyone. And even if you let out the tears and you held someone's hand for a significant amount of time, it just creates a sense of stability. And thank you for listening to me.
It's the empathy that patients want.
Right, and we all go into medicine trying to help and cure, but sometimes that's not, that's not everyone's journey. And if this is a specialty that can be there the whole way through, I think that's very special.
So you keep mentioning cancer, but there are other chronic conditions that you guys treat that are not cancer as well, right?
Correct.
So you don't have to have cancer, your family member, anybody listening who obviously wants to partake and actually have the benefits of palliative care. It could be another chronic condition, maybe
Absolutely.
a chronic respiratory condition,
Correct.
chronic cardiac condition, somebody
Correct.
who's, maybe, I don't know, what other examples would there be?
So basically we see patients, our bulk is our oncology patients, whether that be a solid or liquid tumor. We have a lot of cardiac patients. We see a lot of patients with stage 3 going on 4, New York Heart Association, patients who have some sort of valvular heart disease that either can't have, replacement or whatever that may be, and they struggle with shortness of breath and edema and things like that, so we work alongside with them. Respiratory is something else, pulmonary fibrosis, COPD, are patients that have renal disease, right? And neurologic is another broad one. We treat patients everything from an acute stroke to Parkinson's to Alzheimer's dementia and to even very sad cases like ALS. And we also see patients HIV, AIDS, so our spectrum is as broad as can be. As long as you have a serious illness that requires, symptom management and plus goals of care, we are who you can count on.
All right, so you guys obviously are helping the patient, and we touched a little bit on the family. So talk to us about what palliative care, the team, you and the physician do for the family.
Right. So a lot of the times, to get the family involved early on is so important. Have them understand and be as honest as possible with family members about disease progression, what are things going to look like or change, or have the family tell us what they've seen, what has changed in the home, how the dynamics have affected relationships as far as with their children, with work settings. So we provide that support to family members. We make sure that the family members are in par with the treatment. We answer questions and concerns as far as, disease progression or symptom management or goals of care. So treating the family as you know, is just as important.
As treating the patient,
It's just as important.
All right. So obviously, you as a palliative care physician, you're relatively a new specialty that's been added, something that a lot of us, I say a lot of us that have been here for 25, 30 years weren't comfortable with or understood.
Right.
So what has been the biggest barrier? Is it that people just just ignorance of the healthcare provider or the families, or what's been the barrier? I remember the first time we worked together, I didn't understand, well, what did you want? And you told me, oh, I'm going to help you. I said, okay, yes, of course, come on in, let's help the patient. And it's all for the benefit of the patient. So what do you think have been some of the barriers?
Well, I think the first thing, it wasn't until 1990 when the World Health Organization recognized it as a specialty. However, we didn't get credentialed until 2007 by the American Board of Medical Specialties. So it is very, very new. It wasn't taught to us in our medical curriculum now, let alone decades ago. So to a certain degree, it's very expected that people don't know what in God's name is palliative care, right? So that initiates the misconception. And I think the other obstacle would be kind of what the population thinks of what a doctor should be, right? Doctors should cure, doctors should extend life, doctors should fix problems. But the question is, what happens when the doctors can't fix the problem, right? We have this role in society of that we're supposed to, save a life. For the most part, we do that. There are things that doctors have been able to elaborate, vaccines, antibiotics and things like that. But when it comes to a point that we don't know how to fix a problem, how do we accept that? How are we open with our patients and let them know that, unfortunately, I couldn't cure you, or I couldn't, necessarily take this tumor away. So I think it also starts within ourselves and being honest and open and letting other people take care of those kinds of conversations, because not everyone is the best person to deliver bad news, right? And that's why this is a specialty that we have, a lot of credentialing for to do so.
Yeah, and it's also the fact when you're not the type of physician, as a surgeon how to take out that tumor or cure a patient, but when you can't, then what do? You're kind of lost in how to make the patient's life better, because you said at the very beginning, what you're trying to do is improve the quality of their life, right? Improve the quality of the family's life. And so a lot of us as physicians just never learn that. We never learned that in medical school. And so I think that's where you fit in doing that. Now, one thing you made clear is that when a patient is in palliative care, we're still treating the patient, right? And we're still fighting the disease and fighting cancer, right?
Yes.
Is that something that is commonly questioned or commented and people are concerned about that? Or am I still going to fight the cancer, even though I'm involved in palliative care?
Right, absolutely. Well, one of the main things that we always tell our patients as soon as we meet them, our goals are the same as your treating oncologist. We want you to be cured. We want you to ring that bell. Right? And that's what everyone's goal is that to make sure that we're able to extend your life, that you're able to live a fulfilled life. So, palliative care, we work together with whatever specialty it is that the advanced illness is portraying, and we work together as an interdisciplinary team. If I made some changes and I say, Anthony, this is what I did for your patient, and, he's doing well, and let's continue, and, some things of that nature.
All right. And then also you guys work with something that's called total pain. So explain to us a little bit about that. What does that mean?
So total pain is something that was that we encounter on a very frequent basis, just because pain for us isn't something that is only physical. Pain for us is something that can be, there's kind of 4 different pillars of pain, and most of it is physical, but a lot of it is psychological, a lot of it is social, and a lot of it is spiritual, right? So part of what we do is, some patient may have very distressing symptoms or a bad symptom burden, and treating just the physical pain when we know that psychologically a lot of things are going on, emotionally something else is going on, and they're thinking about how is this going to affect my family. So we try to see pain not just by physicality, but just trying to put the overall picture together, and that's what we call total pain.
Wow. So you guys are not only treating the physical pain, you're treating the spiritual pain, the emotional pain, and then the psychological pain.
Right.
So obviously, what are some of the components for, like, let's say emotional pain or psychological pain or even spiritual pain? You have team members that help with those areas?
Absolutely. I mean, we have patients who their religion or their spirituality is very, very important. So when we identify that, we can call on our pastoral care services and say, I have a patient that would definitely benefit from you. And, they dedicate just a certain amount of time that has no limit to it. And they're able to kind of address that level of pain that they're experiencing
pillar of
maybe
pain, right.
that maybe I won't be able to take away with medication. They can help assist with that.
Well, that's why it's very important that you said it in the beginning. It's a multidisciplinary
Right.
team. You use all aspects. All right. So the ICU, the intensive care unit, is a very important location for palliative care. Explain to us that.
So palliative care in the ICU is more in the acute setting, right? These patients are they're chronically ill, and a lot of the times when we're involved in the ICU could be for many reasons. It could be to kind of put the whole perspective into display for the families, because as you know, when a patient's in the ICU, they just don't have, let's say, a liver issue. They may have blood pressure instability, they may have kidney problems, their respiratory isn't well. So
And they came in with a bowel perforation,
Right.
right? And now they have heart failure,
Right.
liver failure, respiratory failure, and they're on the dialysis CRRT and continue.
Right. So we we go in there and we're like, oh my gosh, there's problem A all the way through Z. And when you start talking about, decision making with family, one of the main things that we get is the confusion. We say, but wait, you're telling me the patient is this, but the oncologist told me this, and the nephrologist told me that, and the lung doctor told me this, and I'm so confused. So we take care of trying to put the whole piece together, trying to navigate, the whole ICU experience. The more we are involved, the better patient satisfaction. There are usually less unnecessary things that are being done that, that can contribute to a patient suffering when they shouldn't. A lot of the things that we do is we do the family meetings, so everyone's on the same page and we're all speaking the same language, and we're all discussing what the plan of care is to move forward. And once everybody's on the same page, family members and patients can make educated decisions. Because if there's one thing I learned in medicine, is that we should never assume that we know what a patient wants. If we don't have that conversation, shame on us, because this person, like I said, has goals and they have, their own autonomy to make decisions. And I would probably say the other thing that we do in the ICU is help with advanced directives and talk about what were to happen. This patient is on a ventilator, and what happens if we can't take them off of the ventilator. We talk about artificial means of life support and what does that mean, not just today, but a month from now, a year from now. Would this person would have wanted to live like this? And very convoluted conversations, and I think we are the most appropriate people to have those conversations with, because that's part of the training that we made. And so it's kind of
it's a lot.
In the ICU, it's a lot.
Yeah, it's a lot.
Not just one thing, but it's many things. And unfortunately, in some cases, we help with withdrawal. And,
Wow.
yeah.
All right. No, I mean, one of the important comments you made there, which I learned very early on in my career, it's not what the family wanted, it's what the patient would have wanted. And I'm very clear when I talk with families, even before surgery, if we have a patient in a critical situation that can't even talk, or after surgery, what would Miss Smith would want? What would
Right.
your mother want? What would your father have wanted? Not what you want, because we're very selfish. And it happened to me personally.
Yes,
Happened with
yes.
my grandmother. I wanted her to get care, and she's the one, no, I don't want any more care. I'm
Right.
done, So it's something you have to kind of understand and be able to communicate.
Right.
So you've obviously clearly laid out for us what you do and what palliative care physicians do, both in the outpatient setting and in the inpatient setting. What do you think has been one of the myths that have to be kind of busted in regard to palliative care that will help expand this and really benefit more patients?
I think the main thing is that we're not hospice.
Okay.
So many times I walk into a room and I say, hi, I'm the palliative care physician, and your primary attending has asked us to talk to you about, and they're like, they look at
They
me
open
like
up their eyes.
they open up their eyes, and everybody gets very tense, and then I explain kind of what my role in their care is, and things kind of ease a little bit more, but it is a scary thought. They think that because we're there, they're passing away tomorrow,
Yeah.
That would be, I think that's that. It's just the correlation to hospice is one of the main things. And I think, unfortunately, one of the number two thing I would say would be some of the medications that we require to use in order to achieve symptom management. People tend to associate that with us hastening death, meaning hoarding it, making it quicker. And, that's not true whatsoever. We are specialized, physicians that do this in a safe environment. We train on how to administer it, to monitor certain signs of distress, and how to recognize if there's toxicity, adverse reactions. So it's not the medication that, that causes the
eventually
death.
causes the death, right?
So I
This
would
is
say
the underlying disease, of course. Yeah.
right. So that is probably one of the biggest myths that we get.
Wow. So obviously, it's keeping an open mind and people being educated about what palliative care is. And that's why I thought it would be an important topic to bring here for our community. And so what advice would you give to our listeners who are listening about this and learning about palliative care, the difference between palliative care and hospice care, and of course, the fact that we have it available at Baptist Health here in Baptist Hospital? Any advice you'd give to our closing remarks and closing advice that you would give to our listeners?
I've thought about this because people ask me, and probably from the years I've been doing this, I think the first thing I would say is that when you go to your appointments, I think it's so important to bring somebody with you. Because if you're going to an oncology appointment and there is the potential of getting news that's not great, you don't receive that. You're not listening.
The last word you hear is cancer.
Right.
And after that, you haven't heard
It's
anything
gone,
else.
right? So I think having an advocate with you, so that can also take this in, extra ears, understanding what is told, because you go home and try to explain it to somebody else, it's very clear that you didn't perceive anything that the doctor told you, right? So bringing someone along with those appointments, it's essential for you understanding. And the more you understand, the better decision making you can have. I would say probably the other thing is that for advanced directives and living will, I think that you don't have to be 90 with an advanced cancer to write out an advanced directive or a living will, just because this is something that everyone should talk about. I'm in my 30s and I have one, and it's because it's important to have it. This is a gift that you give your family members and loved ones. This is what I would want, whether you like it or not.
It makes it so much easier for them later on.
Whether you like it or not, but this is how I want to be treated if something like this work can happen. And if I can't make my medical decisions, this is the person that I know will honor my wishes.
Wow.
That's
That's
simple.
great advice. Yeah, I learned that, obviously with my family and of course, deciding those things ahead of time makes it so much easier for a family. So thank you, Sonia, for coming.
Thank you so much.
Thank you for educating our listeners and our audience in regard to palliative care. Thank you for what you do for all our patients.
Thank you so
and
much.
once again, Dr. Anthony Gonzalez here, educating our community on health topics. Today we talked about palliative care, how it's important in any type of chronic illness that your family members have, and obviously educating you the difference between regard to palliative care and hospice care as well. So once again, Dr. Anthony Gonzalez, on behalf of Sonia Tarras here with us today, thank you for watching us, and once again, be healthy and safe out there with your family. Wishing you a great day from Miami.